Hello Health on LAE is presented by the Ochsner Health System, a nonprofit academic multi-specialty healthcare delivery system dedicated to patient care, research, and education. The Ochsner Health System includes 8 hospitals and 38 health centers located throughout southeast Louisiana. Ochsner, healthcare with peace of mind.
We call it our More Money to Spoil Our Grandkids plan. With a Humana Medicare Advantage health plan, we get tips on how to make our money go further. We even get a health, finance, and benefits statement called Smart Summary that helps us find even more ways to save. And we like more.
More of what you want, because you deserve more.
Good evening, I'm Tom Bagwell, and welcome to Hello Health, a partnership with LAE, the Ochsner Health System, and Humana to bring Ochsner's Hello Health weekly education and information series to television. Tonight's topic, Understanding and Surviving Menopause. Our guest is gynecologist Dr. Shane French. In the second half hour of our program, we'll be taking your questions live by phone at 504-866-3200. That's 504-866-3200. And by email. Just email your questions to us at hhquestions@wlae.com. You can hold off on the phone calls for a while, but send those email questions right away. Well, Dr. Shane French earned her medical degree from Tufts University School of Medicine in Boston. She completed her internship and residency at the University of Mississippi Medical Center in Jackson. Dr. French practices gynecology with special interests in minimally invasive surgery and uterine sparing surgery. Her special interests include laparoscopic gynecologic surgery, including laparoscopic hysterectomy. She is board certified and has been on staff at Ochsner since 2001. And it is our pleasure to welcome Dr. Shane French to Hello Health. Nice to have you with us on the program.
Thank you for having me.
You know, when I heard the accent first and I saw the Mississippi reference, I thought, I'm from Mississippi, so I thought maybe there, but you're from Tennessee, right?
Yes, close neighbor. Yes, I grew up in Tennessee, and that's my grandmother used to regale me with stories about how when penicillin was first introduced into medicine and saved her sister's life, and how insulin was introduced and prolonged my grandfather's life for a period of time. And she had wonderful stories about taking care of everybody up and down our neighborhood. And so I became interested in medicine because of that.
And how did you end up in your area of specialty, gynecology?
Well, I started out as a nurse, and I went to nursing school, and then when I was working on labor and delivery, witnessing the fascinating miracle of life was just amazing. And then I also was very interested in surgery, and so combining those two things together, here we are.
But grew up wanting to be a nurse, and at some point wanted to shift over. And do you remember that shift? Was it an incident?
Well, there was an incident, actually. When I was working in a residency hospital, I used to work the night shift, and I would write all the doctor's orders during the middle of the night. And when the doctors would come through and say what happened in the middle of the night, I would tell them what they ordered and what happened and how things worked out. And I decided, why am I doing their job? I could be doing it as well. So at that point, I went back to medical school.
Very good. Well, we're talking about menopause tonight, so let's begin with the medical definition of it.
Well, the strict definition of menopause is complete cessation of menses and ovarian function, and for at least 1 year.
So no periods for a year.
Right, no periods for a year. And basically that generally occurs between the ages of 51 and 52. That is the age, that's the average age. But what people don't understand is it can happen as early as your early 40s and even into your late 50s. And so there's a huge range, with that being the average. The other part of the definition is it means that at this point you are absolutely infertile. So women are no longer able to procreate. there is a marked cessation of estrogen production, and at some point there is basically no estrogen production at that point. And also with a decrease in the estrogen levels, the estrogen to androgen, meaning male hormones, will become change. That ratio will change, and that's why we'll talk about in a minute why some women will start to have symptoms of things like acne and hair loss.
And we'll talk about more greater detail about those coming a little later in the program. We skipped over pretty quickly the first image, but it's an important one and one you wanted to start with.
Specifically, yes.
There you go.
Yes, because I have so many women come into my office and this is the way they feel. And they feel like they're going crazy, and it's my job, part of what I do is to calm them down and tell them this is not you, this is your hormones, and so, or the lack thereof. And so to try to guide them through the fact that this is actually unfortunately a natural process, but it's something that we can reverse to some degree by using hormone replacement therapy.
Are you part psychologist?
I feel like it some days.
For most women, menopause is a natural state, but there are other causes that you wanted to discuss tonight.
Right. There are two other causes besides just going through menopause normally, and those other two causes are, one would be a surgical menopause, and that just basically means a woman who would have to have their ovaries removed for some reason, which would include things like endometriosis, ovarian cancer, or ovarian cysts that are persistent. The other thing would be women who take medications such as chemotherapy, and a lot of the chemotherapeutic drugs for other types of cancer can cause your ovaries to stop. Some radiation can also have an effect on the ovaries as well.
So if it's natural causes and it's the normal cycle of things, you're not going back. But what about in these other instances?
Well, if you surgically remove the ovaries, you're not going back either. So that, as well as the natural causes, you don't go back. Sometimes the women who have, let's say in your early 40s, you're on chemotherapy agents for another type of cancer, then after your radiation and your cancer treatments have been finished, some women will get their ovarian function back. And so at that point, we have to really be careful to counsel these women on birth control, because they might actually even be able to get pregnant on the back end of that.
What is the normal life cycle for ovaries in a woman?
Generally, the normal life cycle is you start to have cycles at about, the average age is 12, now it used to be 13, and the average end, as we talked about earlier, is 51 to 52. And during those 30, 40 years or so, you have massive amounts of estrogen that is produced, as well as other hormones that we'll talk about in a minute. But those estrogen and progesterone and also testosterone, they are produced at such a high level for a long period of time, and the estrogen specifically is what puts women in general at risk for breast cancer. And as you know, breast cancer, women, if you live to be 70 to 80 years old, you have 1 in 8 chance of having breast cancer. And this is it's mostly a function of that ovarian or estrogen production during that lifetime.
So as we look at it there on the screen, the peak point.
Right.
Okay. You touched on something. It's important. It's sort of out there, but you're confirming it, that young ladies are now having, young women are having their cycles begin and periods begin earlier. It used to be 13,
right.
Now 12.
Right.
Why? And is it heading even further? And do we know why?
Well, it is getting earlier, and we believe it's because of nutrition, because you have to have a certain amount of body fat in order to start menstruating. It's part of the whole, you have to have a certain amount to have cycles. And actually women athletes who lose a certain amount of body weight, they'll stop menstruating. So that's the other side of that. But, and so a lot of it has to do with nutrition. And we, in some of our population, even as early as 9 to 10 years old, is not considered premature at this point.
Does this mean we're eating food is better, or we're eating more poorly? Or fast food have anything to do with this?
Well, increased body fat causes this. So some part of that is better nutrition, but a lot of it probably is we are overweight society.
Okay. And we talked about milk, and maybe how some of it is treated. Mm-hmm. It's not as natural as it used to be. Is that a factor? I've
not seen any data that actually proves that, but it's fat content.
Okay. We talked about the definition of menopause, but as women age, get older, live longer, it's important to look at the history of menopause, and that's something you wanted to focus in on tonight.
Right. Well, historically, women have spent just a very small amount of time of their lives in menopause, and a woman's biological role in life, and this isn't going to go well with some people, but I mean, we are here to procreate.
Biologically only.
Biologically, not. But so that's what we're here on Earth to do. And so in the old days, women's lifespan was only till about 45 to 50 years old, and that's if they survived childbearing. So most of their life was spent, premenopausal. Now women are living average age to be 70, 75, 77, 78 years old. So almost half of our lives are being spent in menopause. And so what used to not be a focus of women's health is now becoming a huge focus of women's health. And menopause for a lot of women is debilitating. And so it's a lot of women need extra care, and that's why we're focusing on hormone replacement therapy.
Delve a little deeper into the 3 hormones that impact menopause.
Well, I call these the horrifically wonderful 3 little hormones. And the first one, of course, is estrogen. Estrogen basically is it's a female hormone that we produce that helps in a cyclical fashion each month to ovulate, and then it also helps to keep their skin plump. It keeps your skin healthy. It keeps it elastic. There are receptors for estrogen all over the body, and they do numerous things. Progesterone is another hormone that is produced by the ovaries. I'm sorry, let me go back. These are produced by the ovaries. And progesterone in a harmonious sine wave type pattern, it helps to stimulate ovulation as well. Progesterone is the hormone that when you do get pregnant, it holds the pregnancy in place. And so it's a very important hormone, especially when you're younger. And then the third thing is something that a lot of women and men just don't understand, but women produce testosterone. And it is a very important hormone because it has so much to do with our libido and sex drive, and also muscle mass, as well as just an energy level, baseline energy level.
Fair for me to ask, do men produce estrogen?
They do a little, but not sort of the inverse. The inverse, probably not as much as we produce testosterone.
Right. How is a woman's skin? You touched on skin and hair, so let's start with skin. How is skin affected by menopause?
Oh, every way you can possibly imagine, and not in a good way. So the skin basically has different. You can see the slide. See the one on the left shows that it's imagine an elastic band is what I tell my patients, and an elastic band can pull and stretch, and it's very elastic and very supple and moist. And when you go through menopause, the skin is made up of 90% of it is collagen, and so during the menopause process, you can lose up to 30% of your collagen, and a lot of that is in the skin that you see over here, and you lose the elasticity, you lose the plumpness, and if you look at older men and women, you see their skin gets very thin. And a lot of that has to do with estrogen depletion. So if you take that one step further, and in the vulvovaginal area, the skin there has exponential number of estrogen receptors. And so the women who are going through menopause, have been through menopause, one of their biggest issues a lot of times, even if they have no other symptoms, is vaginal atrophy and painful intercourse, because there's no elasticity left and it's so thin, it can be very painful. And so that causes major problems.
So even if the desire is there, the libido is there,
right.
Physically,
it can be very painful.
Can be issues. And talk about hair and how that would be affected.
Well, hair it has many different factors associated with that, but one of the things that happens in menopause is as your estrogen levels plummet pretty significantly quickly at the menopause stage, your testosterone levels are also decreasing as well, but not as rapidly, and so you get an inverse in that ratio. So instead of having a lot of estrogen and some testosterone, your testosterone levels bumping up and your estrogen levels are going low. So you therefore will start to have even male pattern baldness, and women will lose hair here. They will lose at the crown of their head, and that's a big issue that we try to help. At least we're not going to make you grow hair back, but we can a lot of times stop the progression of that hair loss.
Do some women naturally tolerate menopause better than others, and if so, do we know why?
Absolutely. I have some patients that come in, I have some of my friends that have been through menopause, and they're just like, what are you talking about? Why are you on TV? What is the big deal? And for women like that, I feel like saying, you know, lucky you. And I'm glad there are people out there that have no issues with that. But, and that is probably less than 10%. Most people will have some symptoms that are at least annoying, that, you know, a lot of times they can live with it. And then on the other end, there are probably about 30% of women that are somewhat debilitated by it. So what causes one person to have symptoms and another, I do not know. That is the million-dollar question.
How much of it is positivity? I mean, you mentioned some of these are your friends. Are these friends of yours who are positive by nature?
That has nothing to do with it. I mean, well, no, let me back up. Some people see a symptom as some people will see one thing as horrible, where someone else might not see it as a bad thing. But when they're not, when people are not even complaining that they've had those symptoms, they either have them or they don't. You know, the degree or the severity of it is not an issue because they don't have them. And so that's interesting.
Have you found there's a correlation between women who tolerate that time of the month better than others and women who tolerate any correlation there between the two?
I do find a correlation that's inverse, actually. Women who have trouble with PMS, horrible PMS, and this is, you know, somewhat anecdotal, so you know, the data is not, there's not been good studies on this, but I have found that my patients that don't do well with premenstrual syndrome and, you know, feeling horrible during certain parts of the month, they do better with menopause because they don't have the fluctuations. So the fluctuations of the hormones are gone, and they're much more stable.
What does research tell us about a link between early menopause and cardiovascular disease?
There's a huge link between cardiovascular disease and early menopause. And I go back and again, this is just, you know, looking at the big picture. There's not a study. There are a lot of studies on this too, but if you think about it, men produce massive amounts of testosterone. They don't have estrogen. Women have always been protected cardiovascular-wise because of the estrogen effect. So even to prove that further is that women who go through menopause early, and what I mean is 40 years old or less, and that is called premature ovarian failure. It can be for the 3 reasons we talked about before. It can be natural. It can be, but we do look into their chromosomes if it's that early, because generally there's some issue. It can be from surgery. It can also be from chemotherapy. But anyone who goes into menopause 40 years old or less is at a 5 times risk of having cardiovascular disease and events. They also are at much greater increased risk of having osteoporosis.
You've talked tonight about that spread where some women will start, you know, most women start around 40, you said? Mm-hmm. Okay. But
well, for menopause, you mean? Yeah. It usually starts late 40s, and the average age of menopause is around 51, 52.
But it can start in the 40s, yes, or before that, yes, and it could start much later, right, late 50s?
Right.
Even?
I have a few of my patients that are still having normal menstrual cycles in their early 60s.
Do we know why the disparity and why some women hit it early and why some women hit it later?
We do not, but it generally runs in families. And when I ask the question, you know, what did your mother do? If their mother didn't have a hysterectomy, because that was a little more in vogue back, you know, when our parents were around, because we didn't have the things that we have now to fix the problems that they used to do hysterectomies for. But if you look at families, late menopause tends to run in families. Early menopause tends to run in families. Smoking will make you go into menopause a little bit earlier than normal. But that is the only thing other than those 2 other things we talked about that can speed it up.
Does a hysterectomy fix the problems?
A hysterectomy is basically, and I want to make a distinction between a hysterectomy and having your ovaries taken out, because the lay people say, oh, I had a hysterectomy, and they think they had their ovaries out, or maybe they're not sure. And some people say total hysterectomy, meaning I had my uterus out as well as my ovaries. But when I say hysterectomy, I mean hysterectomy, and that means the uterus only is taken out. So many of the women's problems are from bleeding issues, and so that's why in the old days a lot of women had hysterectomies. That has nothing to do with your ovaries. If your ovaries remain intact, then your menopause should be, except for the bleeding part, should be the same. So does that make sense? Mm-hmm. Okay, because the uterus is where the babies grow. The ovaries are the 2 organs on either side of it that produce the eggs. And so as long as those are intact, you should go into menopause at a normal time. But you may stop bleeding. Well, you will stop bleeding when you have a hysterectomy, even if it's at 25.
Said in the old days it was a hysterectomy. Is there a trend now for women that we're seeing? as far as what they're choosing to remove or not to remove.
Right. Well, even when I was in training in Mississippi so many years ago, anyone over the age of 40, specifically 45, we were like, you may as well just take your ovaries out now because your risk of having an ovarian problem will be gone. Well, I would never do that to my patients now because we now know that you get so much benefit from that ovarian function, just like we talked about earlier with the premature ovarian failure. It doesn't happen just at 40. Your risk doesn't go from, 5 times to none between the age of 40 and 41. So those risks, slowly recede over time. But no, we tend to do more uterine sparing, ovarian sparing surgeries these days. We've got things like instead of having a hysterectomy, for bleeding issues, we have things like thermal ablation where we can go in and burn the lining of the uterus, and most women that will take care of the problem just in an outpatient situation. We have medications that are better than we used to have back when I was in residency, and we know also that you can use things like birth control pills until women are approaching their 50s if they're healthy to control those things that we used to take the uterus out for.
If a woman is past her childbearing days, has no interest in procreating, make the case for keeping the ovaries.
Well, keep them as long as you can because you may be one of those people that they work for you until your mid-50s or even, not likely to be 60 like the few people I have, but you keep them as long as you can because just because we do have hormone replacement therapy and can treat you doesn't mean that it's going to be exactly like what your body was producing before. And we try to get as close as possible, but, we're not perfect and your own body can do the best job it can for itself, and why take out anything early?
We've touched on this already, but let's delve a little deeper. Functionality. How does menopause affect libido and sexual function?
Well, libido and sexual function is multifactorial, as we all know. I mean, if someone is in a bad relationship, that's not going to, I'm not going to be able to help with with some testosterone and things. But basically, libido and sex drive are run, so to speak, by testosterone. And again, women have it as well as men. We don't have the levels. We would never give you the levels that a man would be taking. But we can replace testosterone, and we do that in different ways. We have pills, we have injectables, and there are patches in other countries. They're not here yet, but we also have creams that some of the compound pharmacies make up for us here. But adding back testosterone for many women it's a very good thing that will increase their libido. And again, I'm not going to make you feel like you did when you're 25, but that's not the goal. And but the libido, the arousal phase, as well as the completion, all that is much easier when people are taking their testosterone.
And self-image, you said, is a factor here too.
Of course.
I mean, you've talked about some of the side effects. The skin doesn't look like it used to. I'm losing some hair, which I am. So all of a sudden, my image itself may not be there. I may not feel as good about myself, therefore I may not want to share myself with someone else.
Well, and those things I can't fix, but when women come into my office and just say, Dr. French, I used to have a wonderful relationship with my husband, he loves me, we have a great otherwise relationship, something's wrong, I could care less if I ever were intimate again in my life, that's not me. How can we fix this? And that is a huge problem. It really causes problems with relationships. And so we do what we can, and we are very successful. With most, I can't fix everything, don't get me wrong, but.
You see women for a living, but is there ever a time you say, I'd like you to bring your husband in for your next visit?
Husbands often come in. Husbands often come in with their wives because it is not, menopause for many women, again, some people have no problem whatsoever, but for many women, it is a family issue. And it causes, because the irritability, the moodiness, the sexuality, I mean, so many different things that the husband will say, you are moody, and you are, because a lot of times the patient themselves don't want to admit it, or they don't recognize it in themselves. I've even had
a lot of this is subtle. It doesn't happen overnight.
Right. And I've even had children come in with their parents or their mother and just be like, she's a different person. Something's wrong. Now, and again, we don't just go, oh, it's menopause. You know what I mean? We look into other things, and I've had patients come in to see me that I say, you need to see a therapist. This is not This is more to it than menopause. And so we look at that. We also look into thyroid function, because during this same time period, women will have, there's a huge increased incidence of thyroid disorders. And so we check that as well when we're looking at the hormone levels.
Positive sign for you as a physician when a husband shows up? That
Yes.
there's that
Yes.
level of interest and understanding and
Absolutely, absolutely. I have rarely had a husband who came in who wasn't helpful. And they often come back, and I've gotten some hugs and pat on the back.
and requests for extra testosterone shots. So let's review the symptoms of a woman will have during menopause.
Okay, the classic, I have a list that I have my patients check off when they come in. And I mean, the classic symptom you always hear about is hot flashes. And, you know, there are several different things, but hot flashes, people have hair loss, breast tenderness, or even like shrinkage of breast tissue, actually. Vaginal dryness is a huge one. Even when people are willing to tolerate all the above, you know, when it comes to their, you know, their relationship with their husband, that's huge. And sometimes we treat just that. And so we'll talk about that in a minute too, because we can cater it to different symptoms. Osteoporosis is a huge problem with women, postmenopausal women, because estrogen does help keep the bones healthy. It slows down the breakdown of bone, and it also helps to build up the bone. And people don't understand that bones are actually in a dynamic process. They are living structures, and so when you lose bone density, it's easier to fracture, and that's one of the huge problems with postmenopausal women and morbidity. So I'm sorry I didn't get the rest of all those, but I'm just going on. Oh, dry skin, irregular cycles, hot flashes, and then headaches, yes.
I gave you a tough time for choosing this image, but you said really there's a good reason we're showing this image,
Right.
because on the surface you're thinking there's no way this woman's in menopause.
Right.
But
that is not true. We have beautiful women.
We don't know about this one particular woman.
Right, well,
but
right, I don't know about her.
Right.
But we have beautiful women. I mean, beautiful women are beautiful till they, you know, till they're 95 years old, 100 years old. But I mean, women who look particularly like this person in the picture, that is not an uncommon person that comes into my office complaining about menopause. And so most people think it's, you know, people who slow down their lives and are not as mobile as they used to be, and are not caring for themselves as much. But a big problem is that you get to the point where, you know, there's a little bit of weight gain, weight shuffling from one area to the other, and this is very, very upsetting to people. And they're like, why can't I get this weight off? And why is my belt tight now? I haven't gained any weight per se, but it's redistributed in a different way. And, you know, I just don't feel great because I don't sleep at night. I can't get a good night's sleep, and because you're up all night with hot flashes and things like that. So it's, it can be debilitating.
Well, we all remember the 7 dwarves, but tonight Dr. French has brought along some of her own renditions of these dwarves to help again illustrate for us
Right.
The feelings of menopause.
Oh yes, and you know, we can go through them, but I mean, you know, the itchiness is from the dry skin, but you know, again, there are several places that itchiness is more uncomfortable than others. You know, the bitchiness, I mean, some women's just ability to deal with, you know, a daily routine becomes very difficult. I have patients who, you know, specifically working in the schools, you know, working in offices where they are very stressed, they will tell me that their job is in jeopardy because they can't handle the stress anymore. And so it's all, you know, it's all related to menopause. There's bloatedness. We were talking about that earlier, where you know, the abdominal girth can change. Sleepiness, and that's because people don't get a good night's sleep for, you know, a month or two at a time. And then just, you know, some people are like, I've just gone crazy, you know, and you know, it can be very life-changing. Very much life-changing. So we try to treat those. And I've even had patients that come in and their biggest complaint, they'll deal with everything, but they're having panic attacks all of a sudden for no reason. Nothing changed. And so we have to back up, and we have to treat that, you know, generally in conjunction with a therapist, but it's related to menopause.
And as we'll see in our next image, a point you want to make tonight and hammer home is there is hope. Yes,
absolutely. Absolutely. This is what we say. We're still hot, but it just now comes in flashes. So basically, you know, what do we do about this? And there are several different ways to treat this. And we were talking about earlier, just the two of us before the program, that, you know, some people come in on a medication for sleeplessness, you know, so a sleeping pill, as well as something for their irritability, you know, an antidepressant type thing, and then also something for anxiety. So they're on 3 different medications that have interactions with each other, and you know, this is all for Not always, but a lot. I can fix this sometimes with something as simple as let's use common sense. Why don't we replace what's missing and then see how your symptoms are, and then we treat those accordingly. And so a lot of women do extremely well just with putting them on hormone replacement therapy. And what I mean by that is estrogen.
Let's hold off on that in a second. Let's get into much greater detail in a moment. We want to remind people that our guest tonight is Dr. Shane French, a gynecologist, and tonight we're talking about understanding and surviving menopause. And we're going to go into that in just a moment, but we want to invite you with your phone calls right now. Here's our phone number, 504-866-3200. That's 866-3200. And our email address is hhquestions@wlae.com. And you can call with your questions right now. And if you don't feel comfortable giving your name, that's okay too. But go ahead and call. Our lines are open. So let's talk about, we've talked about hormone replacement surgery. Let's break them down, those three again.
Okay, so basically there's estrogen replacement therapy, and not everybody needs the same dose, and so we play with the doses.
Yeah, and how do you know? That's a good question. How do you know?
What I do is, when I talk to the patient, we look at their age, we look at their symptoms, the severity, and different symptoms generally tell me, how they're going to do, but then sometimes we just have to play with it, frankly. So we start extremely low, or if you're 45 and you're having menopausal symptoms, you're not going to get away with the dose that I'm going to put a 65-year-old on. So we will start with something, get them over the hump, and then we can start titrating down. So a lot of patients just want to feel better as soon as they can. We can generally get rid of most of the symptoms, the hot flashes and that sort of thing, in a few days. And then at that point, it's a process. Again, we have them come in on several occasions and generally a month apart, and we start them on one thing, then we may tweak a little bit, and then we may add something else. And so you have to think about it in terms of we have to treat the estrogen depletion symptoms and then the testosterone depletion symptoms. And we start with the estrogen and try to get people feeling better with that. Sometimes they need a systemic medication, and we can do pills, patches. We have gels that can do this. We also have injections as well as pellets, and we'll go into that in just a minute. If you are someone who your only complaint is vulvovaginal dryness and painful intercourse, and you are not interested in full body estrogen replacement therapy, we can do a localized treatment for that alone. And so that is something that's not absorbed through the whole body. Even women who have had a history of breast cancer, we can treat for this. I always do it in conjunction with their oncologist, though. So we never put anyone on anything that their oncologist is not comfortable with. And because it is that is a very locally absorbed thing, they're generally okay with that. So those are the things, and like I said, we start with one dose, we tweak it around, and then when they come back and are doing well, we start talking about the testosterone. Many women are not interested in that. Many women are only interested in that. So but most people, it's going to be a combination because the combination works very well. And how do you decide on what dose of the testosterone to use? Again, it depends on if I've got a 95-pound patient, I'm not going to use the 2 milligrams per kilogram that I would use on someone my size. So we just kind of, and again, we play with it and stay within. And progesterone is we use progesterone therapy for, you have to, if you still have a uterus, so you've not had a hysterectomy, your risk of uterine cancer, or the lining of the uterine cancer, endometrial cancer, is there's a significant increased risk if you're taking estrogen alone for a long period of time. And so we saw those in studies that were done back in the 1980s. And what they did was they added progesterone to it. So at the area of the lining of the uterus, the estrogen builds up the lining, and then the progesterone basically fights it so that it doesn't proliferate and hyperproliferate. And so when you add the progesterone, that puts that person back at the normal risk as anyone who doesn't have a uterus. So that's with the progesterone. Now, some people will swear that progesterone alone helps with their hot flashes, and you know what? If that's what you want, then we can work with that too. So,
okay. So you've figured out what it is you need to give a woman and how much, but now you need to figure out how you're going to deliver it.
Right. And everything we talked about as far as the treatment therapy, even with the antidepressants and things like that, this is a conversation This is not me telling a patient what they're going to do. This is a conversation to find out what the patient's comfortable with. I mean, different people have different fears. Different people have different comfort levels with different medications and applications. One patient may say, I can't imagine using a cream, because that's just sticky and, well, not sticky but messy. Whereas someone else is like, oh, I don't want a shot every month. So we work with the different patients and make up their own. They get to help in their plan and how we do this. And so we start with generally something that I tell my patients: patches and pills. You can just rip the patch off if you don't like the way it makes you feel. Stop taking the pills. If we are already working on injections, I can't do that because they last a month. So we start with those things that we can stop, see how you're tolerating the medication itself, and then we'll flip you over into a dose-adjusted injection. And so that will last, like I said, generally a month. And then if you're doing well with that and want something a little bit more long-term, and when I say long-term, I don't mean 10 years, I mean 1 year, then if you're looking for something a little more long-term and more of a steady state, and a lot of people do extremely well, we use the pellets that go underneath the skin in the buttocks, and it is placed by making an incision and putting it with a trocar into the fatty tissue of the buttocks, and it's slowly absorbed over 6 months. And a lot of people do extremely, and we have testosterone that we can add to that as well.
You surgically put it in, but you can't surgically take it out.
You cannot take it out because it is absorbed. It is an esterified estrogen and testosterone that once it's in, the whole thing is absorbed into the body.
But you said you'll be doing lots of testing and lots of kind of feeling out to make sure that's the route somebody wants. You don't just throw it in there and go, man, you're in trouble for 6 months. Sorry about that.
We don't do that. No.
Yeah.
No.
Okay. And more natural ways of dealing with menopause. I know you wanted to talk about those too.
Right. Well, and again, there are some people that really are just scared to death of taking anything that's not. They don't want to take an aspirin. You know what I mean? And so with these patients, we sit down and say, okay, what are your goals? And if your goal is to decrease the number of hot flashes, then there are things that you can do. Look at your nutrition. There are some like isoflavones, which are in soy, things like that can help. You're supposed to exercise always helps control your weight. Don't smoke, don't drink excessively because alcohol tends to make hot flashes come on. There are triggers for hot flashes, and if you can figure out what those are, then most people do a little bit better by avoiding those triggers. There are even the newest studies out that I read last week that there are, like when you're in labor, the breathing patterns, they're saying that they certainly don't get rid of your hot flashes, but they make it more tolerable for people. And I think that has to do with like a Zen type, thing where you're meditating more than anything. And so things that we worry about when you're not taking estrogen replacement therapy, we want to make sure that you get calcium in your diet. Calcium with vitamin D is very important. We will follow your bones with bone mineral density testing every so often, depending on what your results are. We want to make sure that you do weight-bearing exercise for your bones as well, because even like 2-pound weights when you're walking will help. That's considered weight-bearing for your arms, because walking itself helps with your spine and your legs, but you need some weight-bearing for your arms as well.
Our guest is Dr. Shane French, and tonight we're talking about understanding and surviving menopause. If you have questions about menopause, our discussion tonight, you can call us right now. Lots of you already have at 504-866-3200. Your questions coming next at 866-3200, or send us questions by email at hhquestions@wlae.com. This is Hello Health on LAE, more than television.
Because play might be the best way to fight obesity.
Because staying connected makes my family stronger.
Because a safe place after school can lead to success in school.
Because physical activity is vital to my health and well-being.
Because I need to make my world better.
Because playing team sports teaches character and social skills.
Because we need each other.
Because we need each other.
Because we need each other.
My life is full of statistics. Thing is, I could have dropped out of school and become one myself, but I didn't, because I had people that believed in me. Here's another statistic. 7,000 students drop out every school day. That's one every 26 seconds. It's time that students know that we believe in them.
Inspire a student and share your message of support at boostup.org.
Welcome back to Hello Health on LAE More Than Television. Tonight we're talking about understanding and surviving menopause, and our guest is Dr. Shane French. And let's start on line 1 in Metairie with Sandy, who's with us. Sandy, welcome to Hello Health. Good to have you.
Thank you. Thank you so much for taking my call. My question is, what are your thoughts on bioidentical hormones, and do you prescribe them?
Yes, we actually use as much bioidentical hormones as we can, and I just want to back up and kind of explain what bioidentical means. To a lot of people, bioidentical means that it's herb-based and not made by a drug company, but in matter of fact, most of our drug companies can make bioidentical, and they do. And those are the ones that we like to use in our office because we have a decreased risk of embolic event with the bioidenticals. We have a decreased risk of clotting disorders and just other problems that we might face if we weren't using the bioidenticals. The old-fashioned medications are generally oral, and those are the ones where we've seen the problems with them long-term. So yes, we do use bioidentical, and we also have a compound pharmacy in town and also in people's hometowns that will make up things for us, specifically for patients if that's what they want.
Sandy, thank you very much for your question tonight. Let's go to line 2 in Harahan. Francine is with us. Francine, you're on with Dr. French. Go right ahead.
Yes, hi. I've been listening to your program about understanding and surviving menopause, and the other caller did ask a few questions that I was going to ask, but I do have one other thing. You did mention that you do or you can give testosterone, for patients and certain milligrams of it or whatever you think would be well for that person. But are there any side effects to that? And the only reason I ask this is that, I have heard stories in past about deepening of the voice or, facial hair or whatever, and I'm just wondering, are there any side effects to taking that?
Yeah, that is a fantastic question, and it's very important to differentiate between side effects that are not harmful and then side effects that could be harmful. And you actually touched on both of them. Some people, when we start the therapy with testosterone therapy, will have a minimal outbreak of a few acne on their face or a little on their back. Some people will grow a hair or two or even a little downy facial hair. These are things that we warn the patients could happen, probably will happen, but they generally go away after a period of time, maybe 2 or 3 months, because your body adapts, and we're also generally adding that estrogen as well so that you're getting a balance. Things that I would tell a patient, stop it immediately, but it's never happened because we really don't use big doses. But if for some reason someone got a larger dose than they should, it could cause one of 2 things that we say stop it immediately. One is the hoarseness in your throat, and the second thing would be enlargement of some of the female anatomy. And so with those things, we would tell you to stop it immediately. And those, they go away, but we certainly wouldn't want you to keep taking that.
Francine, thank you for calling us. Does that handle it for you? Okay. Thank you, Francine. We appreciate your call tonight. 504-866-3200. That's 504-866-3200. And we're taking questions by email, too, at hhquestions@wlae.com. Let's go to line 4. Vera is on the phone with us this evening. Vera, you're on with Dr. French. Welcome to Hello Health.
Dr. French, I would like to ask a question about my daughter. She seems to be dreading going through menopause, and I think she's in the first stages of menopause because she's very moody and gets very confrontational in her actions with me and with people at work. She's under a lot of stress. Is there anything she can do to lessen the stress She has a very stressful job.
Well, Vera, that's a wonderful question, and I alluded to that earlier when I was talking about the fact that some women do start having trouble at work, and it sounds like this may be what's going on with your daughter. Can I ask about what age range she's in?
She's about 48.
Yeah, that's a typical age where we see a lot of this. But what we would do is if she came in to see us, we would, go through a lot of a questionnaire. We would discuss things. And, a lot of times we do also offer, to see a therapist as well, just so that we're not missing something. I mean, a lot of things can be hormone related, but we don't want to just say, oh, that's what it is, and miss something else that's going on. And sometimes it's not something that, someone needs a long-term therapist or even medication for, but just to work through a particular time in their lives that may be more stressful than others. But we certainly, we are often the port where people come to, and we can, help in this capacity, but we may end up having to refer her to other physicians or just therapists as well. But we would love to see her and love to help take care of this.
Thank you very much.
And Vera will let you know and the rest of our viewers know that this program will be available online on WLAE's website at WLAE.com or on Oxner's website at oxner.org. So if you have a family member or friend who you would want to be exposed to our conversation tonight, please feel free to make that recommendation. The other thing, one of the things you were telling me earlier that you would check is thyroid function. Right. Right? And we haven't really touched on that tonight. Right,
because some of the same symptoms can be triggered by hypothyroid, hyperthyroid, including even hot flashes, especially being very hot or being very cold, irritability, decreased energy, and of course I'm flopping from hypo to hyper, meaning too much thyroid or not enough. But some symptoms are irritability, moodiness. A lot of times it's energy issues, and like I said, the hot and the cold is another thing that we see. So we always like to check that and make sure that that's normal before we just go ahead and treat otherwise.
Let's go back to our phones. Line 3, Martha's been holding patiently, calling us from Metairie tonight. Martha, welcome to Hello Health.
Yes, Dr. French. I was on birth control pills during my childbearing years, went through menopause at 52. The gynecologist put me on Estratest HS, and I have been on it. I'm now 70 years old, and he wants to continue me on it. I'm feeling well. The cardiologist said it's questionable, and I want to know how long can you stay on estrogen. And I've noticed my periods were around the 5th of the month every month, and I've noticed I have not had a hysterectomy, and I've noticed around the 5th of the month, even though I'm not having a period anymore, I notice a little bit of, I'm symptomatic, little pain in the ovary area, and just feel a little more irritable around that time. So I'd like to know, how long can you stay on Estratest? Is it the proper medication for me now? What are your comments on that?
Well, that is the million-dollar question. How long do you stay on it? And so if you look back to what the American College of Obstetrics and Gynecology recommend, they will say, because there are some risk factors about staying on hormone replacement therapy long term. That depends on the patient, their risk factors, and again, you were saying that you're under the care of a cardiologist. This would have to be something that we would discuss. Estratest is estrogen and testosterone. It is a great combination pill that has done very well for many people for a long period of time. And what I would probably say is, I would probably just say, why don't we?
Excuse me. Martha, are you there?
Yes, I'm here.
Can you do me a favor, please? Can you turn off your television for me or turn the volume down?
Sure, turn the volume down, please.
Very good. Our guest is, excuse me one second, our guest is Dr. Shane French, a gynecologist, and tonight we're talking about understanding and living through menopause. Right. And Martha's on the line with us from Metairie, so go right ahead.
And your question was wonderful, and basically she was just asking me when is a good time, when do you come off of a regimen that is actually working for you? And I think that given the fact that you've got one physician that is saying, well, maybe you should try coming off of it, I would suggest that maybe that would be the best thing to do is try to, we'll wean you off off of it slowly, see how you do, and if you're doing well, then you may not need this at this point in your life. You know, again, we would then again, if you were having trouble, we might try to assess it in different ways. But that would be something that I would consider would be just weaning you for a while and seeing, because I tell everybody nothing is forever. I mean, you can always change things. This is not a drug like insulin where if you don't take it, you can get into serious trouble and, you know, go into a coma. This is something you just get uncomfortable and hot and don't feel very well. So.
I don't have any symptoms at all. I will tell you this, my skin looks really great. I feel good. I have a lot of energy. I walk probably 45 minutes a day. I do weights, work out with a ball, and I'm concerned. I mean, really, my body is in pretty good shape for being on it this long, and I'm just concerned with, is that one of the benefits?
Yes, it is one of the benefits.
I've been on estrogen all my life, basically my childbearing years and then after.
Right.
So,
well, again,
I'm just concerned about blood clots. And
right.
Is there a better estrogen therapy than the estrotest?
Well, and that's what I would, if you did decide to, if we took you off, wean you off, and you did decide to say, well, look, I think I felt better on it, I would put you on a different medication, yes.
Martha.
What would that be?
Well, something, the estrotest is not one of the things we consider bioidentical, and so I would probably put you on either a patch or try something with creams, or even like we talked about before, the injections or something.
Martha, thank you so much for thank you for calling. Martha, by the way, that may have been Martha in the picture we were showing earlier.
Oh.
Who looks great, as she just
there you go. There you go.
Just described. Could have
That's
been.
right.
Lots of people on hold. So let's go to line 5. Catherine calling us from New Orleans. Welcome, Catherine. Thanks for holding.
Hi. Thank you. I would love to be in Martha's shoes. I'm in the opposite situation. I'm 49, and I think I've been in menopause for almost 10 years, and I would love to feel as Martha does. I'm wondering, is there a window of time after which you're not eligible for hormone replacement, or it's not recommended any longer? What are your thoughts about that?
Again, you're bringing up all this, the latest studies have been done on everything that you are asking. You're 49, so you are still a good candidate for hormone replacement therapy, is the simple answer to that.
But there is an age, she touched on it. Is there an age where they don't?
Well, the studies show that over 62, and again, they always come up with a date, 61, 63, if you have not been on estrogen replacement therapy at the age of 62 and you start at that point, for 1 year, you do have an increased risk of embolic events, and that's a real risk. And so, but most women who get to age 62 without being on anything, it's not really that big of an issue, but and that was one of the problems with one of the studies that they did several years ago, was that they were initiating women in their 60s, which that's where a lot of the side effects that were not tolerated very well, especially embolic events and cardiovascular problems.
Which is happening naturally anyway, as we get older.
Right.
Okay, but Catherine would be a good candidate at her age.
Yes.
Catherine, thanks so much for calling and for your patience. Let's go to Christine in Terrytown on line 6. Christine, you're on Hello Health.
Thank you so much for this program, and especially for that checklist. I noticed that almost every symptom on that checklist I've just had with a brand new doctor who took me off birth control pills, and he's going to do a blood test on me on next Monday. My question is, will the hormone replacement kind of get me back to normal where I was? And the second part of my question is, two friends have had hysterectomies and they have no thyroid, but they're noticing dark facial hair. So could hormone therapy help them?
Okay, the first, the answer to the first part is that yes. I mean, I'm sorry. Now I'm focused on the second part. The thyroid and the fact they've had hysterectomies, and we talked about earlier on the program, if they've had their ovaries removed specifically, yes, that could be helpful. But that would have to, that's a little more complicated and would have to be looked at on an individual basis. And your question again was?
I've had birth control pills pretty much all my life, and I went to a brand new doctor, and he's fantastic. My doctors over the years have blown me off. Every time I asked a question about menopause, they just said, oh, don't worry about it, don't worry about it. Well, this doctor said, why are you on birth control pills? I'm taking you off. I want to get this out of your system and do a blood test on you next Monday. We'll then see how to proceed with natural hormones.
Right, and that is exactly what I would have done. And because as long as you're on birth control pills, and we do blood tests to see exactly where you are, it's going to be falsely, it's going to tell us where your birth control pills have your estrogen level, not where your body's producing them. And when you get to a certain age, we do like to take you off birth control pills because you don't need those levels of hormone. And what he wants to do is put you on, like he said, a more natural something. I mean, it's probably going to start with a patch or something like that. But it's a much lower dose than the birth control pills, and your risk profile will be much less on that than birth control pills.
Thanks, Christine. Sounds like you found a better doctor. Let's go to line 1. Catherine is with us, calling from New Orleans. Catherine, welcome to Hello Health.
Hello, how you doing?
Fine, good evening.
Hey, Dr. Shane, I was calling. I had a total hysterectomy at 30, and my doctor said that I don't need any estrogen or anything, but sometimes I have a lack of sex drive, and I'm hot and cold, and I'm 40 now, and they said I don't need estrogen. So.
Well, based on what we were talking about earlier, you are by definition a person who has gone through premature ovarian failure, and I would say that you absolutely do need to have some sort of estrogen replacement therapy for your bones and for your heart, and specifically also to make you feel better at this point as well. And you would be a good candidate for that. And so I think that you would feel much better, and like you said, that was very early to have menopause. And
yeah, I'm an active person. When I go in, everything is active. I never was on birth control, and they say that's why I don't need it, because I'm very active.
Well, but you have long-term risk factors that need to be addressed that are underlying all these things. And so even if you're active, you still need to look after your bone and heart health.
That's what I was saying when I go in there and I ask them, and they say my blood work is good and I'm very active. And they don't really give me anything. They just say they'll see me at the next visit. That's basically what they do.
Sounds like you might be in need of a second opinion.
I know. I have 4 opinions. All I'm saying.
Well, Catherine, thank you so much for your help. We appreciate it. And let's take what could be our final caller of the night. Great questions tonight. Line 2, Marie is with us, who's been waiting patiently for Metairie. Marie, welcome. You're on with Dr. Shane French.
Hi, good evening. Dr. French, I just wanted you to know that I've been on estrogen with testosterone since I've been 43 years old, and I'm now 70 years old. And you mentioned something about pellets. I just wanted to know, would you change someone 70 years old to pellets instead of injections?
I would certainly be willing to discuss that with you and find out what your long-term plans are as far as estrogen replacement therapy. We might try to decrease the amount that you're on at your age, but again, I certainly don't want to make anybody uncomfortable. But yes, you're absolutely would be a candidate as long as you understand what we're doing and the fact that it's in there for 6 months and but yes.
The pellets come in, quick follow-up question, pellets come in different doses?
Yes.
They do? Okay,
yes.
Okay. Quick question here, doctor, email question. I'm a 48-year-old that had a total hysterectomy in 1992, and you talked about that earlier. I since have had 2 blood clots, one in the lung and one in the groin after surgery. No longer a candidate for hormone replacements and have since lost all sex drive, have extreme dryness and shrinkage. I've been off hormones since 2004. Doctors refuse to put me back on hormones. Any suggestions? This is from Cheryl. Cheryl, thank you for the question tonight.
Cheryl, that's a very, I keep saying this, but they're all very good questions. And specifically, I know this is very difficult for you because you do have a history that a lot of physicians will just throw their hands up and say, absolutely not, there's no way. And I would say that too, is I wouldn't give you systemic estrogen, but what your complaints are more along sexual function, and it sounds like that we might be able to, and again, I would always talk with your probably hem-oncologist about this, and we could talk about maybe doing something local, like the vaginal creams to help with the dryness and the shrinkage that you were talking about, and then testosterone in a non-oral form does not have the clotting profile that it can in the oral forms, and so that would be something that we might discuss as well. Also, I would encourage you, and if you've probably already done this, but to look into seeing why you had those blood clots, and if you had like a familial disease profile where that could be causing it, and if so, what's being done to keep you from having a clot in the future. So. anything that we would do for you would have to be more of a local situation and in concurrence with your physician, but we are always willing to discuss these things.
Thank you very much to our email questions and to all of our callers tonight. They were, as Dr. French said, some terrific questions tonight, so we thank you for that. And I got to tell you, as a male, this was not the topic I was fired up and ready to come in and do, but you have made it made me so comfortable tonight and wonderful information, been very educational, and thank you for your good work, the education you provided, and for your work at Oxnard.
Well, thank you so very much, and thank you for having me.
Oh, you're very welcome. Well, that is our program for tonight. To make an appointment with any Oxnard physician, including Dr. French, or to register for any of Oxnard's Hello Health seminars, you can call Oxnard at 504-842-5669. That's 842-5669. As a reminder, you can rewatch tonight's presentation, as we've mentioned already, or any of our Hello Health programs. Share it on our website at WLAE.com or on Oxnard's website. That's oxnard.org. Just type Hello Health in the search areas of both sites, and that'll get you going. Our thanks again to tonight's guest, Dr. Shane French. Thanks to Humana and Oxnard for making this program possible. And our final thanks, as always, is to you for your support of this program, Hello Health, and our station, LAE. By the way, we want to congratulate all the folks here at LAE, winners of 2 first-place Press Club Awards, 2 seconds, and a third, I believe. It was a great showing earlier in the week, and we congratulate the team at LAE. Thanks again for watching. We'll see you next time on Hello Health.
Hello Health on LAE has been presented by the Oxnard Health System. 850 physicians and 90 medical specialties working with a team of more than 13,000 employees provide nationally recognized health care across Southeast Louisiana. Oxnard, health care with peace of mind.
I call it my one less thing to worry about plan. With a Humana Medicare Advantage health plan, I get more clear information about my options with 24-hour access to my Humana, my secure website, and I can get help every step of the way from a Humana Market Point representative.
More of what you want, because you deserve more.